Hello everyone, my name is Ho Jun Yoon. I am an upcoming second-year medical student at Wayne State University School of Medicine. The title of my presentation is Non-invasive Therapies for Chronic Subdural Hematoma, How to Make Those Bloody Collections Gone. This project was supervised by a staff member, Dr. Yu Chen Ding. So, before we jump into discussing about non-invasive therapies for chronic subdural hematoma, we need to know the background associated with it. Chronic subdural hematoma is one of the most common neurological disorders. Historically, the surgical procedures have been considered relatively straightforward. However, the challenge is that chronic subdural hematoma is more common among elderly patients who are vulnerable for poor surgical outcomes. Also, they have increased risk of rebleeding before and after surgery, especially due to prevalent use of anticoagulants and antiplatelet agents for other medical comorbidities such as atrial fibrillation. The right side of this slide shows pathophysiology of chronic subdural hematoma. It starts with cells called border cells in the dural layer, which get injured, causing inflammatory reaction. The inflammatory reaction produces fibroblasts and angiogenic factors, which promote the formation of small capillary vessels. However, these vessels are immature and tend to rupture, causing blood products to leak or make any existing blood collections bigger. As a natural response to this, we have coagulation cascade with thrombin and plasminogen and thrombolysis acting against it at the same time. This process doesn't stop here, but continues by increasing the overall inflammatory process. Non-invasive therapies for chronic subdural hematoma target one of these pathophysiological steps, and one of them is corticosteroid. Steroid produces well-known anti-inflammatory effects by affecting differentiation and function of immune cells such as macrophages and B and T cells. Dexamethasone, one type of corticosteroid, may be effective as an adjunct to surgery, and its clinical benefits are comparable to surgery alone. However, at this point, we need more level 1 evidence studies to affirm the efficacy of dexamethasone or corticosteroid. Given the known side effects, dexamethasone should be used with caution for selected patients for now. Tranexamic acid, or commonly known as TXA, is a synthetic form of lysine. TXA inhibits the conversion of plasminogen to plasmin by binding to lysine receptor sites on plasminogen. For its clinical use, more randomized clinical trials are needed to evaluate the definitive efficacy of TXA. Nevertheless, available evidence indicates reduced volume of hematomas and minimal complications associated with TXA. Middle meningeal artery embolization is a procedure believed to reduce immature capillary development and membrane formation. Thereby, it decreases the repeated cycles of subdural rebleeding. There are many case reports indicating the benefit of embolization, especially for recurrent chronic subdural hematoma. However, we do not have a study that assessed the risks associated with embolization, such as intracerebral bleeding, stroke, and vasospasm when treating chronic subdural hematoma. Lastly, we have statin and ACE inhibitors, which are proposed to have anti-angiogenic, anti-inflammatory, and fibrinolytic effects. However, clinical benefits of statin and ACE inhibitors are unclear to warrant its usage for chronic subdural hematoma. So, surgical intervention continues to be the first-line treatment for chronic subdural hematoma. Non-invasive treatment options may be considered as an adjunct therapy, especially for recurrent subdural hematomas or to reduce the volume of resistant or persistent subdural hematomas. Developing guidelines including these alternative therapies may be considered. In the meantime, surgeons remain to play key roles in making individualized treatment decisions.